Well, welcome everyone to meeting number 31 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic. Most specifically today, examining the collateral effects of the pandemic. I would like to welcome the witnesses. From the Canadian Mental Health Association, we have Rebecca Shields, Chief Executive Officer from York and South Simcoe Branch. From the Down Syndrome Resource Foundation, we have Wayne Leslie, Chief Executive Officer. From Focus Education Consulting, we have Kirby Mitchell. From the Canadian Cancer Society, we have Kelly Masadi, Vice President, Advocacy, David Reynaud, Analyst, Advocacy, Stuart Edmonds, Executive Vice President, Mission Research and Advocacy. With that, we will invite the witnesses to give a statement. We will start with the Canadian Mental Health Association. Ms. Shields, please go ahead, 6 minutes.
Well, thank you so much. It's an honor to be here with the honourable members of Parliament and my colleagues. I'm going to get to the point and speak very honestly about what I believe are the top recommendations. You know from the news that mental health is an emerging crisis, but I really want to talk about what you need to think about. In the proposed federal budget, you've looked at investing critical money into mental health services, particularly looking at vulnerable populations and our essential workers. But what I want to really emphasize is two things. You have to invest today in the hotspots. You can't go across Canada. You have to look where it's proportionate and invest directly and think about those communities. If COVID's taught us nothing, it's that if we aren't looking at the communities that are already impacted, then it's going to explode. The fourth wave will be a mental health wave, and we know from the data from past pandemics that those essential and those frontline care workers are facing PTSD. And for those people who are impacted by PTSD, they're 40% more likely to experience a major depression and more at risk of suicide. These are the people that are saving lives today, and we need to be planning for the future. My second recommendation is around how we plan for the future. It's great that you're using well-known and renowned hospitals and research centers, but the investments have to be in local community organizations that have trust and have built comprehensive relationships with those communities where there are vulnerable people. So when you look at the disproportionate effect of the COVID pandemic on marginalized individuals and BIPOC people, we need to look at those community agencies. Why? Because those community agencies are the ones that provide the wraparound supports where people are vulnerable. And so although you might want to do large Canadian institutions, you need to get the money on the ground so that it can be realized quickly for those individuals, because otherwise their vulnerabilities are only going to increase, and which is what we have seen currently in the response to the pandemic in some communities. My last point is that we have an emerging issue around substance abuse, particularly alcohol and cannabis. We know from the data that people who are using cannabis are using, over 50% report they're using more, and there is more binge drinking in other populations, particularly populations who have children at home. So binge drinking is going up. My third recommendation is that you need to have a public health approach to reducing the use of alcohol and cannabis. Look, I'm in mental health and addiction, and I'm telling you, people are using more, and the long-term consequences of using more is it's going to be harder to treat people as this pandemic continues to go on. So we need to use the Public Health Agency of Canada to begin talking about that message to help people reduce the amount that they are consuming. The Canadian Mental Health Association has done a lot of research through Polaris and have looked at the mental health impacts. It is disproportionate, as you know, for women and for women with children. Rates of anxiety are going up. Rates of loneliness are increasing. So with women, now 1 in 4 are reporting great anxiety compared to 1 in 5 men. But still not great, but particularly women with children. And we're also seeing increasing rates of loneliness, particularly in young people, 18 to 39 years old. We're seeing also the impacts of social isolation and loneliness on our seniors. More and more, these impacts of loneliness, depression, and anxiety are increasing, and people are feeling worse off. People are feeling less hopeful than they ever have. In fact, 80% of Canadians report that they no longer feel that their health is improving. I will say that there are some good news points in here. People are feeling like they know how to access care, although they are very concerned about wait lists and whether or not, if they access care, that they're going to receive it. So we need to make sure that those target investments are made so that there is easy access to quick supports. One support in which we have in Ontario is the Bounce Back program that's funded through the Ministry of Health, but this is a telephone-based cognitive behavior therapy specifically designed to ease stress, worry, depression, and anxiety. Programs like that we're trying to promote to go across Canada. These types of services to help people manage and cope are going to be essential for the broad population. But I want to go back in my 6 minutes, which is getting less now, to really what I want to emphasize again. I want to talk about post-traumatic stress disorder, and particularly our healthcare workers and our frontline workers, our nurses and hospital staff, our paramedics, our police, our long-term care home, our home and community health nurses, all of the staff that are working at congregate care settings. It has been disproportionately effective on them. If this is a strain on the population now, our other health services are going to impact Canadians. And again, what we're seeing is that those people are beginning to suffer and burnout is on the rise. If this happens, we are going to have a strain on our healthcare system. So again, I want to urge the look at those investments and look at how we can invest properly. So to further my recommendations, in my last few minutes, I want to talk about trusted community relationships again. Sorry, I don't know what the yellow card means. Is that 1 minute left?
Yeah, but you're actually at 6 minutes, but if you take another minute and wrap up, if you wouldn't mind.
Then I'll wrap up with a final point that I feel that you can make, which is improved access to virtual care through technology. We know that virtual mental health services are making a difference, but there's an equity of access issue. If we can't have equity of access to those vulnerable, BIPOC, multi-generational populations, we are not going to be able to provide timely care, and the crisis will grow. Thank you very much.
Thank you. I should have mentioned the cards. I will try to put up the yellow card when it's about a minute left, although sometimes I get enraptured by your statement and I forget. And the 6 minute indicates, sorry, the red card indicates 6 minutes. So when you see that, please try and wrap up. So thank you very much. And we go now to the Down Syndrome Resource Foundation. Mr. Leslie, please go ahead, sir. 6 minutes.
Thank you. Thank you very much for the opportunity to be here today. The Down Syndrome Resource Foundation provides health and education services for children, youth, and adults with Down syndrome. Based in Burnaby, DSRF is British Columbia's leading Down syndrome provider. We're also recognized for our work supporting families of people with Down syndrome across the country. Classified as a developmental disability, Down syndrome is a genetic condition. It results in a third extra copy of the 21st chromosome that leads to health problems, developmental delays, and learning disabilities. In Canada, 45 to 50,000 people have Down syndrome. So even within the country's smaller disability population, it is a small group that, because of their limited numbers, are often overlooked and marginalized. These factors combine to make them especially vulnerable and disproportionately impacted by this pandemic. For adults with Down syndrome, COVID-19 hospitalization rates are 4 times that of the typical population, and death rates are 10 times higher. Their developmental disabilities also make them more likely to contract the disease because they struggle with, or they can't comply with, safety practices like masking and physical distancing. So in a society where safety protocols are designed to protect the general public, not our most vulnerable, the only safe solution for these individuals is extreme isolation. DSRF believes the main reason we have not seen higher COVID-19 hospitalization or death rates in our Down syndrome community is because they've been cut off from society. One example is the education system. Due to the risk of more severe consequences if someone, even a young person, contracts COVID-19, many students have had to stay away from school completely. Attending in person, which is essential when you have a developmental disability, is too risky, because school safety protocols are just not designed to protect the most vulnerable students. It's a very similar situation for adults with Down syndrome or other developmental disabilities in the workforce. In many cases, they have had to stop working completely. Going to work is too risky. They often perform work that simply cannot be done remotely, so they end up completely cut off from employment. The SRF recommends that efforts to combat this pandemic and other similar health crises should be based on protecting Canada's most vulnerable first. This includes individuals or persons with disabilities, and especially those with disabilities like Down syndrome that often carry significant comorbidities. When schools, workplaces, and communities are safer for individuals with disabilities, they're safer for everyone. The pandemic has also disproportionately impacted families who care for individuals with developmental disabilities, like Down syndrome. Now more than ever, grassroots and on-the-ground organizations like the SRF who work directly with these families see the holes, the inequities, and the fragility of Canada's social safety net that put our families more at risk. Children with developmental disabilities, and disabilities in general, are more reliant on their families regardless of their age. Adjusting to lockdowns is far more difficult when you have children with developmental disabilities whose support systems are either disrupted or lost completely. In normal circumstances, families of individuals with disabilities also face financial inequities due to the added costs for things like critical therapies. As one parent said to me recently, the average Canadian lives in the green, generally good zone most of the time, periodically moving to yellow or caution or even red, critical when they deal with a crisis. Families of individuals with disabilities in Canada live in the yellow zone pretty much all the time. So when the pandemic hit, they went to red, and that's where they've remained. This takes an immense toll. Not surprisingly, demand for DSRF services has increased, but requests for our mental health services have skyrocketed because families now are harshly reminded of just how fragile their situation is, both emotionally and financially. The reality is the way Canada has approached its support of persons with disabilities for years has led to the current state where these families are disproportionately vulnerable, both emotionally and financially. And so they're less able to withstand the extended periods of hardship like those that are being created by the current pandemic. The SRF recommends establishing things like a federal disability benefit to start changing this. With the added pressure that families of individuals with disabilities face, it's clear why current supports and benefits are falling short. I'll finish by saying that while our disability communities have faced significant challenges during COVID-19, you can use this crisis as a catalyst to make positive and very meaningful changes to how they're treated and protected going forward. I believe that the well-known quote from Mahatma Gandhi perhaps sums it up best. The true measure of a society can be found in how it treats its most vulnerable members. Thank you.
Thank you, Mr. Leslie. Go now to Focus Education Consulting. Mr. Mitchell, please go ahead, 6 minutes.
Good afternoon, everyone. Thanks for having me. I'm representing today Focus Education Consulting. It's what I do. I'm an education consultant as well as a teacher. I'm also volunteering with the Worldwide Commission to Educate All Kids Post-Pandemic. And I represent Canada, and we currently have 50 countries involved in this commission. In our conversations, when we refer to the kids that are living through this pandemic, we look at them using 3 buckets of schooling. So the first bucket is a physical classroom. So that's the traditional classroom where kids usually spend most of their time. Then the virtual, online, the hybrid version is bucket 2. And then there's bucket 3, no longer in school. And the commission right now is focusing on bucket 3, students living in that bucket where they're no longer in school. Right now, the commission estimates students living in the third bucket as up to 500 million worldwide. More specifically, there's 10 to 20 million in the US, 60 to 70 million in India, 24 million in Pakistan, 3 to 4 million in Colombia, And here in Canada, the 21st Century Questions, a think tank connected to the commission, estimates that there's right now 200,000 kids living in the third bucket. And that's between grades 1 and 2 population, which is about 5 million in total. So how do we come to this? And when I usually talk about this, I usually try to paint the picture of a school experience pre-COVID. So all of us take ourselves back, and I try to go there as well in this discussion where walking to school in the morning, taking the bus, showing up, and you're standing in front of your school. And then the bell rings. There's students that enter their classrooms for first period. Some people go to the study hall. Some people go to the gym to work out, and some people walk right through to the back of the school and exit. So what's common, what's shared with all those different experiences is a school space. And what we've moved away from because of COVID and the mandated restrictions is that space, the schools. And schools provide beyond just the sports and the relationships and the learning. These are commonly understood as why kids come to school, but kids also come to school to avoid school. And there's a huge bunch of kids that come to that space and they spend most of their time in avoidance and disruption and trying to find their place within a space that doesn't really welcome them. And what that allows for, however, is teachers, admin staff, anyone working in the school, friends, peers, we have an opportunity to re-engage them because they're in a space. And there's actually some barriers to actually leaving, because we must understand students leave school mentally, spiritually, way before they leave physically. And online learning has made that speed of exit grow exponentially. And of classroom, and they're in Mr. Mitchell's class, and there's one tab with Mr. Mitchell's class, and there's a tab a student will have for whatever form of freedom they have. It could be gaming, it could be chatting, it could be exploring a new career. So not all they have to do when they're in Mr. Mitchell's class is, and they don't have a relationship with me, is build walls first. So for example, a student may be having a test in my class, internet kicks off that they can't continue the test, they log back in, and because they don't have a relationship with me, they feel that they can't ask me for more time. So because of that, they say that anxiety builds up. They say either I ask the teacher or I escape through this tab. So what they do is they close the Mr. Mitchell tab. I can't deal with that stress. I'm not going to catch up. I'll never have a chance. They close it and they open that tab and they escape. And that's the frictionless exit that they experience nowadays because of the online space and the way the system has revisited online learning repeatedly over the last year and a half. Pre-COVID, like I said, there was a lot of advantages to come into school. And we had students that were engaged. They're still engaged. We had students that were attenders. They attended school and they showed up for class, but they weren't really engaged. And then we have the avoiders. So the third bucket we talk about is a combination of the students that were avoiding, the students on the margins. I call them students labeled as behavioral. And those are often racialized, Black, Indigenous, people of color that are on the margins and are excluded from school for behavioral reasons. Their behaviors don't follow the norm. How they behave in class, how they behave in the halls. It's a slow streaming push-out mechanism that doesn't allow them to be part of the classroom. They may be the school, they maybe they're sent to a special school, and then early exit. That has been fast-tracked because of the easy exit, because of online learning, and we're seeing that growth at exponential rates. So we see now that's we have 200,000 kids and growing in that population. And because of the recent closure, my concern is the students I'm usually working with that I see in schools or I saw walk around, and that energy of avoidance and resistance, it's no longer there because it's an online space. Either you fit in or you don't. So there's no resistance and there's no place for them to sit. So I don't see them in the halls and I don't see them online. So my feel is even more kids beyond those kids are being excluded, and for various reasons.
If you could wrap up, sir.
Yes, there's students that have ELDs, so they're learning English. There's students that have anxieties built up, and there's students that are struggling from the new learning model, which is online learning. So we're losing those students. And also the rich kid paradoxes, where kids that are traditionally doing well and have all the resources are leaving schools as well. So that combination, because of the last closure, my concern is this is devastating, and we're seeing it not only locally across Canada, but globally with ongoing closures and limitations due to the pandemic restrictions. Thank you.
Thank you. We'll go now to the Canadian Cancer Society. Will it be Ms. Mazzotti to read a statement? Go ahead.
It's actually Stuart Evans will start, and I'll hand over to Kelly halfway through.
Okay, absolutely. Go ahead.
Good afternoon, and thank you for the opportunity to present today, and especially given that it's Daffodil Month or Cancer Awareness Month right now. Unfortunately, cancer does not stop being a life-changing and life-threatening disease in the middle of a global pandemic. More than 1 million Canadians are living with and beyond cancer. While the impacts of COVID-19 will be felt for months and years to come, so too will the needs of people with cancer and their caregivers change as the impacts of the pandemics evolve. While most provinces postponed elective surgeries in some form or another during the first wave of the pandemic, some have fared better in addressing this backlog, but in certain areas, the surgical backlog continues to grow. According to data from the Canadian Institute for Health Information, during March to June 2020, most people with conditions requiring life-saving and urgent surgery received care. That said, nationwide cancer surgeries were 20% lower compared to the same time period in 2019. In Ontario, nearly 36,000 fewer cancer surgeries were performed in the spring of 2020 compared to the year before. Going into the third wave of the pandemic, Ontario had accumulated a total backlog of over 200,000 surgeries across all categories, with some cancer surgeries again being postponed. In Quebec, there were 6% less surgical procedures in oncology performed compared to last year, and that represents around 2,200 surgeries. Through trends in inquiries to our information and support programs and ongoing national surveys of people facing cancer and their caregivers, we have a sightline into the continued impact disruptions to care are having on people affected by cancer. A July 2020 CCS patient survey found that almost half reported having their cancer care appointments postponed or disrupted during the first wave of the pandemic. We are concerned that a third wave in parts of Canada will result in even more disruptions to cancer care. The severity of surgical backlogs must not be underestimated. Results of a study involving Canadian patients published in the British Medical Journal suggests that people whose treatment for cancer is delayed by even 1 month have about a 10% higher risk of dying. Risk also increases the longer it takes for treatment to start. Now I'll turn it over to Kelly Mazzotti.
Along with the immediate impact that COVID is having on cancer surgeries and treatments, we're concerned about a tsunami of cancers yet to be diagnosed. Since the start of the pandemic, global cancer diagnoses have seen a dramatic decline, estimated to be at about 40%. In Ontario, from March to December of 2020, nearly 1 million fewer cancer screening tests were performed compared to the same period in 2019. In Alberta, more than 170,000 tests, including an estimated 40,000 mammograms, were suspended for 2 months, starting at the end of March. Au Québec, des estimations récentes prévoient que...
In Quebec, recent estimates indicate that nearly 5,000 Quebecers having cancer haven't been diagnosed.
Programs help find cancer earlier, when it is easier to treat and outcomes are better. We are concerned that the disruption in screening programs will lead to cancer cases being diagnosed or treated too late. We must continue to encourage people to get screened, and cancer systems must plan for the disruptions caused by COVID-19. COVID-19 has also interrupted oncologic care across the spectrum of cancer care. A survey from the Institute of Cancer Research found that cancer researchers fear advances for patients could be delayed by almost a year and a half because of the effects of the COVID-19 pandemic. In Canada, clinical trials were affected to various degrees across the country. These trials can provide access to promising therapies to people with cancer, and in many cases, patient recruitment was paused provincially due to assessment of available staff, healthcare resources, and patient safety. COVID-19 has also undermined public health efforts at disease prevention and health promotion. For example, local public health units have shifted staff and resources to work on COVID. A good example here is tobacco, with large numbers of public health staff who work on tobacco enforcement and smoking cessation redeployed to the COVID-19 response. Through all of this, governments must lead the response with a comprehensive and coordinated plan of action to address the future burden of cancer in Canada. The response must include all levels of government, the public, charitable and private sectors, academics, policymakers, politicians, and citizens. The impacts of COVID-19 on cancer control, as well as the increase in the number of cancer cases due to an aging, growing population, highlights an increased need for healthcare services and providers, infrastructure, caregivers, family support, and other types of programs and services. There will be a need for more support for the increasing numbers of cancer survivors. Focus is required on planning of cancer control programs for prevention, screening, early detection, treatment, palliative, and other medical care. Research is needed to help plan for this increase in cancer cases and to identify more solutions for effective treatment and supportive care for those with cancer. Je voulais vous remercier pour votre...
I would like to thank you for your time today, and it will be our pleasure to answer your questions. Thank you.
Thank you. So we will start our questioning now. We'll start with Mr. Barlow. Mr. Barlow, please go ahead, 6 minutes.
Thank you very much, Mr. Chair, and thank you for everyone's testimony today. I want to start with you, Ms. Shields, and it's good to see you again. You know, I had a phone conversation a couple of days ago with a constituent who called a 19-year-old girl, very upset. Her 20-year-old brother had committed suicide a few weeks ago. An apprenticing electrician laid off as a result of lockdowns, found a job in a restaurant, lost that when lockdowns were extended, and just the isolation and had got the best of him, and he couldn't handle the depression, and he took his life. And I know many of us on this call as members have had similar conversations with constituents, but this is becoming an all too common occurrence, I think, with many of us, that we're having these types of calls to our office with people who are completely distraught, and this suicide has certainly devastated this family. And I had a virtual town hall with a lot of business owners and community leaders with similar stories of depression and anxiety and suicides. And I know when we spoke, you know, late last year, you were mentioning a recent study in December that showed the mental health of Canadians had, you know, been, you know, 40% of Canadians had said that their mental health had deteriorated. And we saw the numbers of substance abuse up, suicides up, and that was December. What is as these lockdowns and restrictions continue, and you talked about a mental health fourth wave, which I've never heard it put that way, but that's very disconcerting. What do you anticipate, you know, the longer these lockdowns and restrictions go on, what the impact is going to have on a Canadian's mental health?
Thank you for the question. We know from previous pandemics that it is going to decrease. So why, to really understand the why of that, you're right in the sense of uncertainty and vulnerability are disproportionately impacting people. So for example, communities that have precarious employment, just like that, I'm so sorry about that young individual. Of course, that economic stress, uncertainty can lead to, you know, obviously can lead to depression, anxiety, and of course that is at risk of suicide. So that's going to happen. So we know that from past pandemics. We saw that from SARS. We saw that there are populations that are at higher risk than others. And that's what I was sort of trying to get at. So who's at higher risk? Essential care workers, whether that's our hospital staff or the people that have been front lines or the people who have been impacted by COVID, absolutely are at high risk. Particularly communities that have been high impact by COVID. So when I said, BIPOC people, so people who are precariously employed, lost employment, are at the front lines, who have suffered from COVID, are at risk. There's a general increasing of anxiety and depression. And what I try to suggest is women and women with children, families with children, are tending to have higher increases of anxiety. We also have our youth, and sort of people have been touching on that, and my colleague, Mr. Mitchell, was touching on the impact of young people and the increase in anxiety. And so what is that looking like in terms of the impacts of social isolation? But then when social isolation becomes loneliness, that trips into chronic loneliness. Right. And when we get into chronic loneliness, that's where we have outcomes that are equivalent of smoking 15 cigarettes a day, that my cancer colleagues will understand how serious that is. So you're right. This is what we are preparing for, which is the fourth wave. What are we trying to do? We're trying to increase immediate access to care, but we have to do it in two formats. First and foremost, we need to be planning and training early. I need people on the ground today so that they're there tomorrow. I can't wait. We can't wait to have trained workers in language or cultural specific communities available for people. Because if they have to wait, that risk of suicide increases. And what we know, and it's really important to understand, is somebody can go into a hospital and they get discharged. The most at-risk period for suicide is the 30 days following a discharge from a hospital. So we have to have programs that are available right away to transition people to, and that's where you need to bolster the communities. You need trusted community partners that can begin to wrap around supports of these individuals. Organizations like myself, we provide counseling, we provide employment, we provide housing, we provide food security. So when you look at what we can do in terms of supporting navigation and community supports, we have to work with our hospitals and our acute care centers to stabilize people, but then we have to provide that ongoing care and transitions. And, I know I'm talking to people who know and understand this. So my recommendation is you've got the National Suicide Prevention Strategy starting. It's going to take a while, but that $1 million or that $50 million investment has to come in immediately, and you've got to put it into the communities that are hardest hit.
Yeah, thanks. And just want to build on what you said about having people on the ground immediately. And I'm sure you were talking about the PTSD within frontline healthcare workers. How frustrating is it for them not having, what I've heard is that stop and start. We're going to have vaccines. We're not going to have vaccines. We're going to have rapid tests. We're not going to have rapid tests. How much of an impact has that had on their mental health of not having, more of a clear path to accessing vaccines and rapid tests for those frontline healthcare workers?
So uncertainty is a trigger for all of us, right? So uncertainty leads to higher stress, and higher stress, what we're dealing with is people that are in acute stages of stress and chronic stress. And what that means is that they're at high risk of trauma, which means at higher risk of depression. So trauma, depression, suicide, right? So really that's what we're trying to build out is trauma-informed and trauma-specific services for our communities. Thank you.
Thank you very much. Thanks, Mr. Chair.
Can't hear you, Ron.
Ron, you're on mute.
Sorry, I'm trying to use the keyboard thing, and I guess it fails. Anyway, thank you, Mr. Barlow. So we'll now go to Mr. Van Bynen. Mr. Van Bynen, go ahead, please. 6 minutes.
Great. Thank you, Mr. Chair, and thank you to all of our witnesses for joining us today and sharing their experiences and their concerns with the pandemic. It's a great honor to be able to welcome a constituent to the committee and have their voices reflect in the work that we do here. So I'll be directing my questions to Rebecca Shields from CMHA, York Region and South Simcoe, and acknowledge that she serves a population over 1.2 million people across more than 10 different municipalities. Firstly, Rebecca, I want to thank you for the many projects that you've undertaken in conjunction with community partners like York Region Police, South Lake Regional Health Center. Now you put together teams to respond to situations that are urgent and often call for police presence, but also has the presence of your team so that you can respond effectively to these. Now, last fall, I moved a motion in this committee to study the impacts of COVID-19 on mental health and the well-being of Canadians. And that was well more than 4 to 5 months ago. And I referred to mental health as being the third pandemic, and it's become the fourth pandemic now. And I very much understand what your concerns are. You supported the call for this study and said that to achieve full economic and social recovery, we must understand the true impacts of the pandemic on mental health of Canadians. And I completely agree with you, and I thank you for that support. I know that it's critical to invest in comprehensive community-based research to understand the impact and identify the most promising strategies. And you made some references around hotspots. While this committee has the scope and the scale of this committee is more broadly countrywide, what would you suggest we would take, or how would we go about trying to identify the community-based strategies?
Thank you so much for that question. It is really true that each province and territory addresses healthcare differently. However, mental health affects us all. And so, but we do have unique community needs. And this is what we're seeing. So, at the very basic, when we understand that COVID, which is a healthcare issue, impacted different communities differently, same disease, completely different impacts and outcomes. So what we're learning from the research of COVID, we have to kind of translate that into local neighborhood-based research. We can pull data from our hospitals around, and we do, and share that information. But what does it mean to have population-based research? Well, there's many components of that, and there's some great leading practices coming out of, for example, the Slate Center at CAMH, where they're looking at youth-specific research. One of the things that they're sharing is in co-design and co-participatory research is how COVID is impacting youth differently. Not all cohorts of youth are the same. Some might be thriving at home and then the Honorable Mr. Mitchell said, or my colleague Mr. Mitchell said, some are not. And how do we understand and address that so we can be designing and delivering services that are effective, and so that we can take a health equity approach? So in community-based research, that what we want to have is we want to have the lens of health equity across that research, and then to be able to co-design and deliver services that are effective for those communities. So the research must be embedded in community. It must be co-designed. It must take into account a population ethnocultural lens so that we can have a health equity approach, as well as other cultural specific groups, like my colleague Mr. Leslie said, developmental disabilities, 2S LGBTQ, our Indigenous communities, our Black communities. All those communities have their own needs, and so as we design and break down research, we need to not just stay at a global level, but really take the investment to dig a little bit deeper, because we know that responses must be designed in order to meet specific needs. And the pandemic has shown us this. If we do not take into specific populations, they get left behind. And without that health equity lens, they're disproportionately impacted. And so we can do better. And that's what I'd like to see us do. Thank you again for your question. I hope I responded.
Thank you. The access to mental health resources and supports has been key during this pandemic for many Canadians. And our government has stepped up with the Wellness Together Canada and the Kids Helpline. And I know that CMHA had their own telephone-based supportive counseling. My question is was this a service that was in place pre-pandemic? And if so, can you elaborate on the changes or the differences between before and during the pandemic that you noticed, or that your staff has noticed?
Sure. Well, first and foremost, obviously, like all mental health agencies, we switched to, as much as possible, virtual care. So that allowed access to people. And again, I did mention that we do need to ensure equity of access. But what we did do is we offered specific counseling for frontline healthcare workers. We offered a variety of just walk-ins, so really trying to take away any sort of wait list, so a lot of like walk-in or call-in services in order to address immediate needs. We expanded the access to the bounce back program through an investment so that we could not have anybody wait for that over-the-phone based cognitive behavior therapy that addresses, it's an evidence-based form to address worry, low mood, stress, and anxiety. So those are the type of investments that we made to quickly address population health. And then we did deeper dives into specific vulnerable populations like our homeless population. I see the red card, so thank you very much.
And thank you for all the good things you do for our community.
Thank you, Mr. Van Bynen. We'll go now. Nous allons maintenant, Monsieur Thériault.
We will go now to Mr. Thériault. Go ahead, Mr. Thériault, 6 minutes. Thank you, Mr. Chair. I'd like to thank all of the witnesses for their contribution to our understanding of the collateral effects of the pandemic. I will first ask the Canadian Cancer Society my questions. When we started studying the pandemic at the beginning of the first wave, a number of witnesses came to tell us that the chronic underfunding of health networks had weakened our healthcare system and that there would be catastrophic effects coming into the future. And at that time, we had two hopes: finding a vaccine quickly and also ensuring that there was only one wave. Now we are in the third wave. Your comments complement those of Dr. Bélanger of the Quebec's Association of Gastroenterologists and Dr. Champagne, the spokesperson for the Hematologist Association, who told us that COVID-19 would lead to other types of victims, non-COVID patients. We know that the fight against cancer requires early intervention. And when there is no early detection, then we see an increase in costs and an increase in the risk of dying. We've even been told that the collateral effects of the pandemic in the area of the fight against cancer would be felt during 10 years, with an increase in the risk of dying of 10% year over year. The government didn't include anything in its budget, even though the provinces and Quebec called for them to invest 35 cents on the dollar rather than 22 cents. So it's a $28 billion question. There could have been a partial or full investment, but there was nothing, no announcement for the next 5 years. That could change. But that political decision to not provide the capacity to take action, to treat people, to invest in healthcare, and make forecasts, because we need predictability. From the medical and health point of view, it doesn't make sense. If you had to convince the Prime Minister to change his mind today, what would you say to convince him to invest recurrent, predictable funds in healthcare, especially in the area of the fight against cancer? Thank you.
Well, thank you for the question. Obviously, the concern that we have, we share the concerns that you expressed about the future state of cancer control over the next few years. And certainly, there are things that the governments across the country can do right now in terms of maintaining surgery procedures, but also screening programs and also promoting those programs as safe programs to encourage patients to make the most of those programs and to get checked out when they need to get checked out when they have concerns. I'll turn it over to my colleagues Kelly and David to see whether they have any comments about certainly what we would how we'd bring this up to the federal government.
Oui, bonjour.
Good afternoon. First, thank you, Mr. Thériault, for that question. We could look at this from two angles. First, how do we address the impacts of the pandemic in short and the medium term? So the different healthcare systems throughout the country need to work at over 100% of their pre-pandemic capacity. So to catch up on those backlogs in surgeries, but also in the area of screening and early detection. So we'll need new resources for that. When you increase capacity, you increase spending on staff, you modernize equipment and infrastructure, and so we would need new resources for cancer units throughout the country. Then we can look at it from the medium and long-term angle in terms of care for people. If with an increase in the number of cancer cases, nearly 1 Canadian out of 2 will be affected by cancer. So we'll need to find a concerted approach with a long-term vision and predictable funding to address these issues that are coming towards us, so we can address them in a way that allow Canadians to have the best quality of life possible, so that different healthcare systems can address their costs and have better prevention and better screening. And in terms of how and why, we encourage the government to work with charities, with the provinces, with the private sector, with researchers, with citizens, to find the best possible solutions, to have that long-term vision and that predictability for the future. You agree with me. Dr. Bélanger said there are 150,000 patients waiting. 63% have waited longer than they were supposed to. A colonoscopy costs $1,000, but if it's not done in time, we wind up with a patient who has cancer, a chronic disease, who will have a lower quality of life and an increase in mortality, but there will also be much higher costs for the healthcare system. So the decision to not invest in healthcare right now will lead to an increase in costs and a decrease in our capacity to properly care for people. And we won't be able to save costs. And do you agree with me?
Est-ce qu'on a le droit de faire un petit coup?
Can we say a little something? Do you agree? You must? Yes. Yes, on the general point. Yes. Thank you. Thank you, Mr. Chair.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
Mr. Davies, 6 minutes, please.
Thank you, Mr. Chair, and thank you to all the witnesses for your excellent testimony. Mr. Leslie, I'd like to direct my questions to you, if I may. I know that you have been a champion for raising the particular vulnerabilities of people with Down syndrome, and particularly the need to make sure that they're not forgotten in terms of prioritization for vaccination. I'm wondering if you could expand on the reasons for your call, and in particular, if you have any comment on the federal guidelines on vaccine prioritization and whether you think they should be amended specifically to recommend priority access to people with Down syndrome or other developmental disabilities.
Thank you for the question, Mr. Davies. We have DSRF is primarily a service provider, but this issue became very quickly a pressing issue for our community. We took the opportunity to use our leading voice to assist our community in a population, as I mentioned, that's often overlooked, to raise the attention of the fact that it's a uniquely vulnerable population. Even within the general developmental disability community, it's a smaller subset. Because of the comorbidities that go hand in hand with the genetic condition that is Down syndrome, as I mentioned, they're 4 times more likely to be hospitalized and 10 times more likely to die if they contract COVID-19. And because of their associated disabilities, they're increasingly more likely to contract the disease. The challenge that we identified very early on was that the focus was simply on, and understandably, why people were dying, and that's what needed to be protected. But we quickly tried to shift the focus to the fact that if we didn't do something to prioritize uniquely vulnerable groups, and if they weren't unusually isolated in a way that many families would say, as it extended, bordered on cruel, they would eventually be the next victim in a second or third or fourth wave. And the only reason, again, you haven't seen that is because they've been extremely isolated. And so they need to be shifted in terms of how you're viewing those priorities. One of the key issues that we've had is that despite Down syndrome being a very well-known, smaller, but well-known disability, there's often this gatekeeping that comes up where people and persons with disabilities find this problem a lot, where they have to do an unusual amount of proving they have a disability. So there were unique vulnerabilities that we felt at the beginning should have been easily identified by the medical community and national leading organizations that focus on immunization priority, and recognize that some of the larger questions are more complicated. But there were some, I would describe it frankly as low-hanging fruit. And Down syndrome would be one of those disabilities that could have easily been identified long before it was. The community should not have had to fight for the vulnerability that was so obvious, not just the people in the communities themselves, but in the broader community as well, generally speaking.
Thank you. Now, I'm very familiar with the wonderful work that the DSRF does for our community and specifically focused on people living with Down syndrome. But I also happen to know that DSRF activities and supports extend beyond that to the broader developmental disabilities community at large. So I'm just wondering if the comments that you made specifically about those living with Down syndrome are more broadly applicable to people living with diverse needs typically, and what you could tell us about the impact of COVID on the broader developmental disabilities community as well.
Thank you. It's a very good question. The simple answer is the same things we're talking about extend through the broader community. I'll touch on my colleagues from education, from cancer, from mental health. The important thing to remember is whether you're talking about a developmental disability like Down syndrome or other disabilities like cerebral palsy, autism, along with their disabilities, they have mental health issues. They have health issues. They have cancer. They have education issues. So they're the vulnerable of the most vulnerable. So this cuts across all of the populations, which underscores one of our key recommendations, is that we need to be able to work more. We understand in a priority crisis management, putting out a fire situation, why you need to focus your efforts on people who are literally dying. But taking the opportunity to think more forward, we need to approach the recommendations from a perspective of here's an opportunity to make sure that we're taking care of the most vulnerable. And persons with disabilities as a larger group are not an insignificant part of our population. And we need to start emphasizing the need to take care of them, whether it's federally, provincially, or locally. So everything we're talking about Down syndrome, while Down syndrome has a unique set of comorbidities that ramp up the vulnerabilities in health, we share a lot of risks and vulnerabilities across the entire developmental disability perspective.
I'm wondering if you know, this may be an unfair question, but generally speaking, roughly what percentage of the Canadian population would identify as having a developmental disability, to help us get a bit of a quantitative scope on this?
I don't have the exact number. Part of that is because, respectfully, Down Syndrome Resource Foundation works very more directly with, obviously, Down syndrome. But it would be a significant part of the population when you consider the simple fact that it includes those who are on the autism spectrum, which now we've recognized after years of research and the medical data backs up that people that we thought had no developmental disability do in fact do. So I don't have an exact number, but I don't think I would be exaggerating by saying it is significant.
Thank you. I see I'm getting the red card. So thank you for your answers, Mr. Leslie.
Thank you.
Thank you all. That brings our questioning to a close for this panel.
We actually have 8 minutes left, Chair. Can we have a brief second round?
Sure. We'll have to shoehorn that in. Do we want to have a 1 minute round for everybody, for every party? That being the case, we'll go with Ms. Rimple-Garner. Go ahead for 1 minute.
Thanks, Chair. I just wanted to direct an additional question to Mr. Mitchell. I read a CBC article you were quoted in where you were talking about the difficulty that students are having in reaching students in virtual class, which you spoke about. Just with the remaining time I have, I was wondering if you could expand upon the forecasted impact that you think this is going to have on the high school dropout rate across the country?
Well, the most recent closure, I believe, is having a cumulative effect on students. So the first closure, there are some students that resisted and stayed in the system, but some left. Second time, a little bit more left the system. And at this point, I believe, as with teachers in the system, they're tired, and they're tired of the promise of being back in school versus looking forward and seeing an actual end to this. So I see with the summer coming and the weather changing, students, especially in high school, because we have the quadmesters, there's a quadmester coming next week. I'm concerned that this may be an easy exit, as I was talking about, for a lot of students to kind of disengage, leave school in the upcoming weeks. So every day counts. Every day we're going to lose 100 to 1,000 kids as they feel less engaged and less connected to what they formerly knew as school and family and community.
Thank you, Mr. Garner. We'll go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead. 1 minute.
A question for Mr. Mitchell as well. I certainly understand what he's talking about. I've got two little kids over there online as we speak. What can we do right now to help kids to make sure that they stay in the system?
Well, I want to invite everyone to our commission's meeting. We're having one next Friday, and it's a Canada-wide summit where we're gonna come up with a plan. And basically it's all hands on deck. We're going to try to look at the students that are in the third bucket, living in the third bucket, and over the summer, re-engage them, reconnect them, revitalize them. And by September, all teachers should be vaccinated. We're hoping that we can have a transition informed by what they knew from the previous system, what they knew from the current system, and what they want moving forward. So it's a student-informed or child-informed process, along with the experts in the building. But we had our chance. Let's see what the kids want now. And September, we hope there's a place that's welcoming to as easy as a welcomer at the door saying, "We want you back." We want it to be that granular.
Send us a link.
I'll send you the link for sure.
Thank you, Dr. Pawlowski. We'll go now to Monsieur Thériault. Allez-y, s'il vous plaît.
Mr. Thériault, you have 1 minute. Go ahead. Thank you. To the Canadian Cancer Society. Earlier we talked about wait lists. So there we have patients who are already known to the system. There are also invisible victims. Cancer prevention requires screening. Based on your experience with the prevalence of cancer and cancer development every year, those invisible patients, those we're not talking about, but who are victims right now, who are invisible right now, what would be the quantity per year?
David, would you like to take this?
Oui, ben c'est ça. Ben encore une fois, merci.
Once again, thank you for the question. It's difficult to quantify because each healthcare system is different. The ramping down has been different, but it would be probably thousands of people who have cancer but haven't been diagnosed. In Quebec alone, it's been estimated it's about 5,000 people who haven't been diagnosed. And a study has indicated that that could lead to 8,000 to 10,000 deaths in Quebec alone over the next 5 years, in addition to what we currently have. Thank you.
Merci, Monsieur Thériault. Mr. Davies, please go ahead. 1 minute.
Mr. Leslie, if you could give one or your best recommendations to the federal government how we could best promote inclusion of people with Down syndrome in society, what advice would you give us?
In simple form, pay more attention to them. It's a group that, and I use again the Down syndrome community as an example. While we recognize that federally there might be challenges with getting that granular, but it's a good example of how vulnerable groups, because of their size and proportionately speaking, even the larger disability community and population is still smaller relative to the size of the overall population. You need to pay more attention, and that needs to be more than, to be frank, it needs to be more than lip service. It needs to be more than just political solutions. It needs to be thinking about how to bridge the gaps. I think there's a real role, even though a lot of these issues we're talking about, I recognize and DSRF recognize are under provincial jurisdiction. There's a role to play federally. There's opportunities to create partnerships and leverage. And a good example of that was some of the funding that was rolled out as part of the emergency response that DSRF was able to leverage through United Way that helped us support the development of mental health programs. The risk we have now is while those were great, they're short term, they're emergency. They will go by the wayside, we expect, at some point. And then you have those gaps, and some of my colleagues spoke to those. So there are opportunities and roles to play. I think that this is the catalyst we're talking about, where you can use what you're learning through this particular crisis to really draft a better way of supporting persons with disabilities in Canada in general in the future.
Thank you.
Thank you, Mr. Davies, and thank you all. Thanks to the witnesses for sharing your time and your expertise with us here today. It's most helpful to our study. And with that, we will suspend and bring in the next panel. We are suspended. Resumed. So welcome back to meeting number 31 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic. Most specifically today, examining the collateral effects of the pandemic. I'd like to welcome our witnesses. As an individual, we have Dr. Gary Block, family physician and associate professor, St. Michael's Hospital and Inner City Health Associates, University of Toronto. With the Canadian Medical Association, we have Dr. Anne Collins, president, Dr. Abdos Shaba, Quebec board member and French spokesperson. With the Canadian Federation of Nurses Unions, we have Pauline Worsfold, Secretary-Treasurer. With the Mustard Seed, we have Mr. Stephen Weil, Chief Executive Officer. Thank you all for attending today and for sharing with us your time. We will now start witness statements, please, with Dr. Block. Doctor, please go ahead, 6 minutes.
Thank you so much. Good afternoon. I'm a family doctor, a professor at the University of Toronto, and a senior fellow with the Wellesley Institute. And I have experience in social policy development as a member of Ontario's Income Security Reform Working Group. Over the past year, I have spent most of my working hours on the medical front lines of the pandemic, in my clinics at St. Michael's Hospital and the Good Shepherd Homeless Shelter, in a COVID homeless recovery site, and recently at a COVID vaccination center for Indigenous people in Toronto. This infectious disease pandemic has been challenging, but every day I battle social pandemics. I work with communities that are disproportionately impacted by adverse social conditions, including poverty, homelessness, and systemic injustices caused by racist and colonial social structures and policies. The scientific evidence is powerful. These social pressures have a massive impact on health, including higher rates of chronic and acute illness, adverse childhood outcomes, and death. In COVID-19, the communities I work with have faced greater hardship than most. This infectious disease pandemic, placed on top of the long-standing social pandemic, has created what is termed a syndemic, a synergistic pandemic, in which the spark of COVID has ignited the tinderbox of social inequity built into the structures, policies, and institutions of our society. We have known since the first months of the COVID crisis that the people getting sick and dying live in poverty and without adequate housing, work in high-risk frontline jobs without adequate employment protections, and are racialized, disabled, women, Indigenous, and more often than not impacted by intersections of multiple identities. I ask you to urgently call for health, public health, and social resources to be redirected to neighborhoods and communities with the highest burden of illness and with the least protections. This includes extending emergency income benefits, guaranteeing employment supports like paid sick days, and facilitating access to health supports such as a safe supply of opioids. But deeper structural changes to our health and social systems will be required to prevent this situation from recurring. And I have 3 recommendations for this committee. 1, strengthen social support programs to provide a foundation for health. This week's promise of a national child care program is an important step. I suggest this committee examine income support programs to ensure all Canadians have access to an adequate income to attain and maintain good health. This could include extending basic income programs beyond those currently in place for seniors and children, with particular attention to the needs of people living with disabilities, Indigenous, and others who face historical and structural barriers to living above the poverty line. I also suggest this committee call for a commitment to end homelessness through increased funding for affordable and supportive housing and housing first programs. 2, collect data to make social pandemics visible. We must improve social disease surveillance systems. To properly understand health and social outcomes, we require access to disaggregated data on race, ethnicity, income, disability, housing status, and other key determinants of social inequity. Public institutions and community agencies should be directed and supported to gather, analyze, and report on social data at a community and individual level. I suggest this committee demand specific health and social outcomes targets for those who've been socially marginalized, with regular reporting and accountability to those targets. And 3, empower those who have been most impacted by adverse social conditions to lead these changes. I've been giving vaccinations at the Aduje Mino Nesewinong Clinic, a program created and governed by Indigenous people. Using their knowledge and community connections, they have provided extensive services to an urban Indigenous community that has long been hidden from view. I suggest this committee advocate for this approach, often called nothing about us without us, to be replicated for other projects and other communities, putting those who are most impacted by inequitable social policies in the driver's seat of efforts to redress those inequities. These changes will set the foundation for a recovery that aims to address the disastrous inequities that have characterized the COVID syndemic. Thank you.
Thank you, Doctor. We'll go now to the Canadian Medical Association. I believe it would be Dr. Collins to start. Go ahead, please, 6 minutes.
Thank you, Mr. Chair. It's my honor to appear before you today. My name is Dr. Ann Collins. I am a retired family physician. I've taught family medicine. I've run a full-time practice. I've served with the Canadian Armed Forces, and I've worked in nursing home care. Just yesterday, I was called back into service to administer much-needed vaccines to people in my rural home community. Mr. Chair, I am honored to appear before you at this time in the pandemic, representing the physicians of Canada and the people they care for. I am joined today by my colleague, Dr. Abdou Shaba, CMA board member and emergency physician serving on the front line during the pandemic in Quebec. As president of the Canadian Medical Association, I am gravely concerned about the state of the pandemic in Canada today, in particular in hotspot regions where we are facing extreme circumstances. I applaud the federal government for its unrelenting leadership and unprecedented action in leading our national response. The pandemic has been unrelenting in challenging the physicians and health providers on the front lines, and the third wave is hitting hard. The CMA is deeply concerned about the toll COVID-19 has taken on the people who will steer us out of this health crisis. Emergency doctors are working 12-hour shifts and being required to work another 4 hours, day after day. Fatigue and anxiety are high, threatening burnout, and yet there is no relief in sight. Medical professionals are being trained on critical care triage protocols, which may be enacted to respond to the lack of resources. If enacted, physicians will be in the untenable position of making the difficult life and death decisions about who gets care and when. The moment we have dreaded and feared, when the pandemic's grip is surpassing resource capacities in some regions, is here. The CMA implores provinces and territories to continue to act in the spirit of collaboration to ensure that our resources are deployed where they are needed. We must work together for the common good to prevent loss of life wherever possible. Some areas of risk have already benefited from the aid of resources shared by the premiers. Most importantly, today is critical care staff. To call these actions laudable is an understatement. The CMA commends the federal government for its leadership in encouraging and facilitating this deployment of national resources. Canada's recovery is contingent on the recovery of our health systems. We vigorously applaud the recent commitment of $4 billion to resolve the backlogs of the first and second waves. I cannot stress too profoundly the incredible urgency for Parliament to pass Bill C-25 without delay. Still, more is needed. Today, 5 million Canadians do not have access to a family doctor or a family care team. That's 13% of the country. If our healthcare systems are a house, primary care is the front door. The drafts are increasing. There's no security when the front door is off its hinges. Primary care is affordable. It fosters equity, and it will be the cornerstone of healthcare, supporting the people in Canada through and out of the pandemic. Expanding primary care will help ensure every single Canadian has access to a family doctor. The right to access healthcare must not be subject to our status or postal code. Every marginalized and susceptible person in Canada deserves the attention of a primary care team. Our nation has never been in more dire need of health security. The CMA appeals to Parliament to deliver this critical health care resource. There's still time. The pandemic has exposed the weaknesses, shortages, and lack of capacity of Canada's public health care systems. We must begin to chart the course in reimagining public health and health care. The long-term mental health impact of COVID-19 on frontline healthcare workers is coming. We must prepare for it. All of this will require a commitment to increased and sustained funding from the federal government. The CMA welcomes the Prime Minister's pledge to engage the provinces and territories in a continued and collaborative plan to address the future of our health systems. The financial commitments the federal government has made to support Canada's pandemic response are exemplary. Investments to date will improve lives. They will save lives. But there are still some steps missing that lie before us. Completing them will allow all Canadians an equitable opportunity at health security. Completing them will sustain our frontline healthcare workers in the fight they face today and the care they must provide in the future. In conclusion, Mr. Chair, let me thank the committee for the invitation to share the convictions of Canada's physicians. The CMA and its 80,000 members will be there to fully support the government in addressing the stability of Canada's health systems. Thank you.
Thank you, Doctor. We'll go now to the Canadian Federation of Nurses Unions. Ms. Worsfold, please go ahead, 6 minutes.
Thank you. I want to acknowledge I'm speaking to you from Treaty 6 land here in Edmonton, Alberta, and give thanks for the 4 peoples taking care of the land prior to our arrival. My name is Pauline Worsfold, and I'm a registered nurse, and I'm here today to speak on behalf of Canada's nurses. I serve as Secretary-Treasurer of the Canadian Federation of Nurses Unions, CFNU, which represents approximately 200,000 nurses and nursing students across the country. This is an elected position, and I've held it since 2001. I also work as a staff nurse in the post-anesthetic recovery room at the University Hospital in Edmonton. In fact, I got off work this morning at 7 o'clock, and I have been requested to work overtime. That's from 7 to 11 tonight, ahead of my next night shift. As a registered nurse for 40 years, I can speak firsthand to the collateral effects of COVID-19 on our healthcare system and the people within it. I see my colleagues and fellow nurses and healthcare workers across the country struggle to manage psychologically with crushing and unsafe workloads. While healthcare staffing shortages have existed for far too long in this sector, COVID-19 has brought in an already overstretched workforce to its breaking point. In 2019, the Ontario Nurses Association said the province would have to hire over 20,000 nurses to reach the country's average staffing ratio. The nursing shortage is so bad in Ontario, you've all seen the news, that the Ford government is pleading for nursing support from other jurisdictions. It breaks our hearts. We all want to help. The reality is, throughout the country, we're all experiencing shortages. It's time to sound the alarm, and these staffing shortages will have dire consequences for our nursing and broader health workforce beyond COVID-19. The CFNU conducted a study before the pandemic and we already knew nurses were suffering mentally, in part because of staffing shortages. 1/3 screened positive for major depressive disorders and suicidal ideation, and more than 1/4 screened positive for generalized anxiety disorder and clinical levels of burnout. 1 in 2 identified having a lack of staff to adequately cover their unit as the #1 source of extreme stress in their job. Burnout has worsened dramatically over the course of the pandemic, with nurses being unable to take leaves and working ceaseless hours of overtime on virtually no rest. A StatsCan survey of 18,000 healthcare workers found 70% reported worsening mental health during the pandemic, and nurses are the hardest hit. Without urgent and comprehensive action, we risk an exodus of frontline nurses and other healthcare workers when we emerge from the pandemic. Our Outlook on Nursing survey, which was nationwide, it was conducted just before the pandemic. More than 66% of nurses rated their work environment as fair or poor, and 60% said they intended to leave their job within the next year, with 1 in 4 of these same nurses saying they intended to leave nursing altogether. In fact, I work with people who were on the cusp of retiring, 1, 2, 3 years, but they're going in the next 6 to 12 months for sure. Unfortunately, I'm not one of them. A recent survey of nurses in Ontario found 13% of nurses in the early career, age 25 to 35, were considering leaving the profession permanently after the pandemic. According to a report from La Presse, 4,000 nurses have already left their positions in Quebec during the pandemic, which is a 43% increase over previous years. How will we be able to manage with a growing number of nurses leaving the profession when we have an enormous backlog of surgeries and procedures? How will we fill the ballooning vacancies of nurses and other healthcare workers with over 100,000 vacancies and so in the health and social assistance sector at the end of 2020? How? What is needed now more than ever is federal leadership to address critical nursing shortages across the country through targeted transfer of funds to the provinces to immediately begin hiring more staff. To ensure a sustainable supply of nurses and other healthcare workers to meet growing demands, we need the federal government to help us address health workforce information gaps that would enable adequate health human resources planning. The federal government could address this through establishing a health workforce agency reflecting international leading practices, and in particular in Australia. This could fill the data gaps that limit our ability to retain and recruit the workers required, giving us the tools we need to manage the frightening shortages and vacancies we are currently experiencing. We have the opportunity to ensure nurses and other healthcare workers have the supports they need going forward, but we have to act, and we have to act fast for the sake of our nurses and the health and safety of our patients, residents, and clients.
Thank you, Ms. Worsfeld. We'll go now to the mustard seed with Mr. Weil. Mr. Weil, please go ahead, 6 minutes.
Hello and warm greetings to all in attendance, including the members of the committee and to the chair of the committee. My name is Stephen Weil. I'm Chief Executive Officer of the Mustard Seed, and thank you for having me here today. The Mustard Seed is a Christian nonprofit organization that's been caring for individuals experiencing homelessness and poverty since 1984. Operating in 5 cities across Alberta and British Columbia, the Mustard Seed is a supportive haven where people can have their physical, mental, and spiritual needs met and grow towards greater health and independence. Our vision is to eliminate homelessness and reduce poverty where we serve. Currently, we serve in Calgary
Edmonton, Red Deer, and Medicine Hat in Alberta, and Kamloops in British Columbia. Our mission is to build hope and well-being for our most vulnerable citizens through Jesus' love. Through this past year of the pandemic, our vision and mission remained unchanged. But how we do this has required creative adaptation, resilience, flexibility, and grace to respond to the ongoing changes while staying focused on serving those in need. This dramatic transformation in our world has provided an opportunity to expand our reach and find creative solutions to help even more of our vulnerable neighbors. In times of need, when our clients have no one to care for them or a place to call home, to provide safety, we are there with open arms and a welcoming spirit. The pandemic has changed many things, but our client and staff's well-being, their health and safety has always been our main focus. The trends we have seen this past year are, first of all, increased unique individuals experiencing homelessness in some of our locations. The overall numbers in our shelters were down, and yet we saw unique individuals experiencing homelessness increase. In Edmonton, for example, the number of unique individuals using our shelter services increased by 15%. Secondly, those who experience homelessness have increased risk for COVID due to barriers in following public health directives. While we're able to provide a space in Calgary for those experiencing symptoms to isolate, many who experienced homelessness in other cities were unable to easily isolate as a close contact or being symptomatic. During the beginning of the pandemic, many public spaces were shut down, causing increased challenges for accessing spaces for individuals to remain warm or bathrooms in which to practice appropriate hygiene. Thirdly, significant collaboration between health and social service agencies in the cities we serve, resulting in increased partnership and collaboration to provide wraparound supports not only in relationship to COVID, but to improve the overall health of this population. This has resulted in deep, rich partnerships with other homeless serving organizations. This has been essential in containing the spread of COVID in the shelter system, but also creating a coordinated effort to provide vaccination to our population. Fourthly, vaccinations have been a challenge, as our overall homeless population in Alberta, for example, have only been eligible for vaccination since April 19th. While many individuals were eligible prior due to their complex health concerns, transportation, and booking for these vaccinations were significant barriers to them accessing them. The rollout in Alberta, for example, has not been optimal because of a lack of understanding, in particular by Alberta Health Services, of those experiencing homelessness. And fifthly, increasing overdoses, substance use disorders, and acute mental health concerns. We have seen an increase in maladaptive coping strategies for the social isolation, the lack of comprehensive and available services, and the general anxiety due to the pandemic. For a period of time, we had to close our wellness center due to public health restrictions. So moving forward, my recommendation is, one, provide funding for a significant increase in affordable housing. The current and proposed funding for affordable housing barely touches the need, as demonstrated by the Rapid Housing Initiative this past year, and the overwhelming response to that initiative. Secondly, funding health supports in the shelter system itself. This not only includes primary care, but also allied health professionals who can target the multifaceted health needs of this population and the increasing acuity of mental health and substance use disorders, which this pandemic has not only revealed, but exacerbated. Mental health is highlighted in the literature related to this vulnerable population and the pandemic, and for good reason. We have seen the acute effects in our shelters. Providing increased mental health supports is a dire need and difficult to provide during the pandemic. Thirdly, ensure the vaccine supplies are targeted to this population. An effective strategy of care is created to ensure that all who consent to it receive their second dose in a timely and efficient manner. And finally, after the focus on vaccines and triaging the current public health crisis ebbs, a longer-term strategy for approaching and funding the wraparound supports that the mustard seed embodies across the sector is encouraged. All of this in addition to housing. This pandemic has laid bare the need for increased mental health and substance use disorder supports in the long term, where individuals are moved out of homelessness, not only into permanent housing, but also into a system that ensures multifaceted care to address their social determinants of health and prevent for future homelessness. Thanks again to everyone, the members of the committee, to the chair of the committee for having me here to speak about the work we do at the Mustard Seed. As we say at the Seed, hope grows here. Thank you.
Thank you, Mr. Wild. And thanks to all the witnesses for your statements. We will start our questioning now with Ms. Rimple-Garner. Please go ahead, Ms. Rimple-Garner. 6 minutes, please.
Thank you, Chair. Mr. Weil, thank you for everything that you do in our community. What's really struck me throughout the pandemic is actually the lack of dialogue on the impact of the pandemic and related restrictions on Canada's homeless populations. You know, I know there's a lot of us who are growing weary of stay-at-home orders and stay-at-home restrictions, but we're very privileged in that we have a home to stay in. I think you've given the committee some very concise recommendations, but I'm wondering if you can expound a little bit, perhaps in sort of like bullet point formats, of some of the impacts of COVID on the homeless community in Calgary.
Be pleased to. Yes, there's one of the really positive things about Calgary to start with is that the number of people using the shelter system across Calgary is down significantly. And the reason why I think it's down significantly is because many of our clients have been motivated to move out of the shelter system into homes. For example, in Calgary alone, we've placed almost 450 people this last year into permanent supportive housing. So there have been some positive outcomes. The negative outcomes, however, are things like lack of access. Our shelter systems have certainly expanded from overnight shelters to 24/7, but of course, many in the homeless community do not want to spend their entire day in a shelter, and so they're wandering around, especially throughout the winter. The difficulties are plus 15s typically were havens of warmth for them. Those weren't available to them any longer, and so it caused them to face more of the difficulties that you have with the elements, and so those are some of them. Some of the restrictions. The ability to find food has been an issue as well. Many of the people that are in the shelter system are bottle collectors, and so of course, people aren't throwing away as many bottles because if you're in Calgary, for example, I don't know what the percentage is, but we're at least down 50% of the number of people that come downtown during the day or stay around the downtown core, and so that impacts them as well.
So I guess just following on that, I'm concerned about ensuring that the homeless population in Canada are adequately thought about in terms of vaccine rollout. I would imagine that some of the challenges would be access, information getting to people, booking appointments, and then also giving your clients tools like a vaccine card or something. Are there any challenges that you're identifying right now that you think need to be rectified in short order in order to ensure equitable access for your clients to vaccination?
Yeah, I think one of the obstacles is for our clients is there's often a lack of trust, right? And so the people they tend to trust are the people that are there to serve them. which would be, our shelter workers, our street level workers. But one of the difficulties we're facing right now, and we have an example where in British Columbia, Kamloops, our shelter service received their vaccinations at least a month earlier than we did in Alberta. And one of the things we discovered in Kamloops is when we booked our clients for a vaccination, the response rate was about 30% of our shelter clients who wanted to get a vaccination. When we booked our clients in coordination with our staff, whereas our staff were getting their vaccinations at the same time as our clients, the rate moved to 80%.
Okay.
And so we've been telling Alberta Health Services, if you want this population to get vaccines, then you need to have our support workers get their vaccine at the same time as an example to them. And unfortunately, it's fallen on deaf ears. In this past week, we have vaccinated 90 of our clients, of approximately 250 or so.
Mr. Weil, I don't want to cut you off because I just have
no.
about 30 seconds left and I want to get this on the record. Is there anything, because I know the federal government is starting to do some education on vaccination, is there anything specifically at the federal level that you would recommend to the committee in terms of that education component, how to target that to your clients and help partner with you on that information providing service?
Yeah, I think overall there needs to be a deeper level of communication with the people on the street, the service providers, because this is a unique population, and if we treat this population like the rest of the population, we will likely have difficulties, getting the level of vaccination that we feel is necessary to protect this group of people.
Thank you for everything you do. Thank you, Chair.
Thanks.
Thank you, Ms. Trample-Garner. We'll go now to Ms. Sadhu. Ms. Sadhu, please go ahead. 6 minutes.
Thank you, Mr. Chair. We know our communities and our medical professionals are under an increased stress in the third wave. My community is a hotspot of COVID-19. I want to thank all frontline medical workers and nurses and doctors saving Canadians every day. My question is to Dr. Collins. We know our government announced new supports to Ontario, including sending federal healthcare staff and equipment to frontlines and more. In your testimony, you referred to an additional $4 billion from the federal government towards the Canada Health Transfer to help provinces get through this pandemic. What are some immediate needs you think the provinces should be targeting?
Thank you for the question, and through you, Mr. Chair. We commend the government for the added $4 billion directed to address backlog and $1 million for vaccine delivery. We are not yet fully aware of what the impact of this pandemic will be on backlogs. We know that there have been incredible increases in wait times. We know that people have delayed seeking medical attention. And so what that will lead to is, of course, diagnoses that are much more complex when they arise, and the need for diagnostic and treatment services will be that much more complex as well. We also feel that it's imperative that there be a commitment to a previous promise that every Canadian should have and can have a family doctor. We know that primary care is critical in how we deliver care to Canadians, including what is going to be needed post-pandemic, and also the incredible requirement, or that what we anticipate is going to be needed to provide mental health care, not only to healthcare providers, but to their patients as well as we come out of this pandemic.
Next question is to Dr. Block. Dr. Block, my mother is presently undergoing treatment for cancer. She's fortunate to have family members supporting her. Can you speak to how patients with serious illness are able to cope when they do not have a support network especially those with COVID-19. What issues do you see among low-income and racialized communities, and what solution do you propose?
Thank you so much for that question. And I will say that my mother-in-law is actually undergoing treatment for cancer as well, so I've experienced this personally. What I see amongst my patients is that what it takes to address health issues is truly being magnified. It's being magnified by the COVID pandemic itself and a lack of access to services, both within hospital and primary care services, although we are certainly doing our best to support people. But it's also magnifying the social divides and the barriers and gaps that we see in our society, right? So what were previously for some a lower level of barriers are rising, right? So people who live in high-risk neighborhoods, especially people who are racialized, people who live in high-risk buildings, especially people who are low income, find it even harder to access supports and access medical care than they did before. I think there are a number of ways that we can approach this. For a start, I would echo what Dr. Collins put forward about the need to put primary care at the forefront of our health system response. I think that it is truly primary care providers who can come from within the healthcare system and dig most deeply into the realities of people's lives. This is what I spend my time doing every single day. This is true of people who live in low-income situations, who are socially marginalized, and as Mr. Weil pointed out, people who are right on the margins and who are homeless, right? We are the ones who are truly accessing people everywhere. I will say, though, second of all, that we need to look at a higher systemic level of support. So when we talk about the fact that people who are racialized and low income have more difficulty accessing services, we need to think about why that is, right? We need not to look at the individuals, but at the systemic factors behind that. There is real racism built into our systems, which pushes people who are racialized away from accessing care. So we need to do a deep dive as a healthcare system into understanding why that is. First of all, by collecting and looking at data to allow us to understand what the experiences are of people who are racialized, who face other elements of social marginalization. And then by targeting specific healthcare and social services towards those communities to correct those inequities. And when it comes to addressing the needs of people who are low income, I don't want to sound pat, but I think that the answer is actually not all that complicated, right? I mean, people living at low income requires a response of increasing access to income. I certainly see that, and I've always seen that as a health relevant response to a health relevant issue, that we need to urgently ensure our income support programs provide an adequate income for anyone in Canada to live and to survive.
Merci. Thank you, Ms. Sadu. Nous allons maintenant, Monsieur Thériault.
We now move to Mr. Thériault. You have the floor. 6 minutes. Thank you, Mr. Chair. I'd like to thank all of the witnesses for their contributions to our understanding of the collateral effects of this pandemic, especially non-COVID patients. The Canadian Medical Association indicated today they gave us an overview of the situation, and it has a lot to do with the management of the pandemic. We haven't heard much about the collateral effects on non-COVID patients. Dr. Bélanger told us recently from the Association of Gastroenterologists in Quebec that the urgent must not make us forget the important. And in fighting cancer, well, we know that cancer doesn't stop for pandemics. Dr. Collins, I have the impression that you have a very clear vision of after the pandemic. When will that be after the pandemic? Because you said earlier, there's during when we need to act, and we're pleased with the funding during the pandemic, but we need to see after. When will it be after the pandemic?
Merci de votre question.
Thank you for your question. I will direct you to my colleague, Dr. Shabab.
Dr. Collin, merci.
Thank you, Dr. Collins. Thank you for the question. The question is very relevant. It's true that the trajectory of the pandemic will be aggravated by the collateral effects, the backlogs in medical procedures, and our association prepared a report recently to clear the backlogs in October of last year. And in the conclusions, we saw that there was additional pressure that would be put on systems, and that's what we experience every day. You've talked about what's urgent and what's important. Today we're dealing with what's urgent, but in the report we also talked about what's important. Actions like hip and knee replacements, cataracts, which have an impact on quality of life, and then medical imaging that has an impact on diagnosis and also on survival. And so we have significant backlogs now in those procedures and a significant increase in wait times. Inaudible and unintelligible. So consequently, we are asking for all levels of government to increase access to primary care so that we can resolve those backlogs that are piling up. You heard about this during the first wave of the pandemic, and now there's a second and the third, which will have an impact. Dr. Champagne from the Association of Hematologists and Oncologists of Quebec spoke about an article in the British Medical Journal that indicated that impacts would be felt over 10 years with an increase in the mortality rate of 10%. A 4-week delay means an increase in mortality of 6 to 8 or 10%. It's very clear that we need to increase resources. The Nurses Association spoke about a shortage in human resources, which we need to do surgeries which can resolve a cancer. We need all of those people in the operating room. From a medical point of view, does it make sense to say that there will be substantial recurrent increases in health transfers only after the pandemic? That's why I was asking the question. When is it after? Does it make sense economically when we know that a colonoscopy costs $1,000 and that if we don't do it in time, we'll have a chronic patient in the system, and the costs to the system, well, the longer time goes on, the more the costs will go up. So does it make sense to say we'll invest recurrently after the pandemic, that it will be done substantively after the pandemic? Is that medically and even economically justifiable? Thank you for the question. Once again, I think it's extremely important to increase those health transfers and to support the provinces during and after the pandemic. I think you're right that we need to focus on what's urgent and we need to plan for what's important. At our association, we believe that constructive dialogue on the best funding model that would ensure that patients from all jurisdictions have access to the same level of care today, during the pandemic, and after the pandemic, and those discussions on the increase in transfers for after the pandemic should be held, and we look forward to participating in those conversations in the coming months. $4 billion is good, but the issue is of the scope of $28 billion for Quebec and the provinces. And when we start negotiations, we don't know if we'll reach that. The federal share, the federal government share, needs to be higher. We knew that our healthcare systems were already struggling to correctly treat patients. So imagine after a third, maybe fourth or fifth wave. So now we need to plan and invest. Do you not agree? Certainly. There needs to be much more, but we would like to thank the government for that $4 billion to deal with backlogs. And we urge all parliamentarians. But it's not recurrent. And the important thing is predictability and recurrent investments so that we can foresee what can be done. Thank you very much.
Merci, Monsieur Theriault.
Thank you, Mr. Theriault.
Now to Mr. Davies. Mr. Davies, go ahead, 6 minutes.
Thank you, Mr. Chair. Dr. Collins, on April 16th, the Canadian Medical Association issued a release that said the following: we are at a critical juncture where a truly national approach to combating COVID-19 will make the difference between more and fewer lives saved. We act as one country when crisis hits with wildfires, floods, and other tragedies. This pandemic has reached a new level that requires a national response. We are one country, and it's time we started acting as one by deploying resources where they are most needed. If we can't achieve this through voluntary cooperation, then more and stronger measures might be needed. Right now, Dr. Collins, we're seeing a severe crisis in Ontario. ICUs are overwhelmed. Doctors are being compelled to take people off ventilators if they don't have a 70% chance of survival. This is an emergency. In your view, should the federal government play a stronger role and use its authority under the Emergencies Act to deploy resources where they are most needed?
Thank you for the question, and through you, Mr. Chair. I'm afraid I'll have to defer to legal experts who would be in a better position to address Mr. Davies' question. I do, though, however, want to commend the federal and provincial leaders who have signaled their intention to support the crisis in Ontario by encouraging healthcare professionals within their jurisdiction to answer the call of duty. I can say that the CMA's members, too, are eagerly seeking ways to help and are ready to volunteer their time and put themselves at risk to help the acute care crisis emerging in certain jurisdictions across the country. Thank you for the question.
Thanks, Dr. Collins. On April 20th, you released a statement in response to Budget 2021 that said the following: we are disappointed that this budget did nothing to address the problems faced by the nearly 5 million Canadians who must navigate medical issues without consistent access to a family doctor or primary care provider. The federal government has committed on numerous occasions to ensuring each Canadian has access to a primary care professional, but we have yet to see any real commitment to this ongoing issue. What will be the impact of this lack of action?
Primary care is the front door to, thank you for the question, and through you, Mr. Chair. Primary care is clearly the front door to the healthcare system. And as I've stated earlier, we don't know the full impact of what the pandemic has had with respect to wait times and so on. But we know that those Canadians who do not have a family doctor are going to have a much harder time navigating the system to deal with issues such as their mental health care. We know that seniors need strong access to primary care. We've not mentioned it today, but patients with long COVID are going to need primary care. So we need to see a commitment to delivering on that, to expanding the role of primary care teams. And also we need to start being more innovative and look at how we deliver healthcare with respect to the social determinants of health and taking in the many issues beautifully outlined by Dr. Block around equity in healthcare.
Thank you.
Thank you.
Ms. Worsfold, on April 19th, the CFNU put out a news release commenting on Budget 2021, and it quotes CNFU President Linda Silas saying the following: Canada's nurses were counting on the government to honor its previous commitments, including implementing universal public pharmacare, developing national standards for long-term care, and meaningfully responding to the growing funding crisis in our healthcare system. It is disappointing that little progress has been made on these critical issues. In your view, how will those failures manifest themselves on the ground in the year and years ahead?
Well, since I'm on the front line, I see it on a regular basis where people now don't have benefits coverage, and so stop taking their medication. end up in the emergency room with a bleeding ulcer, let's say, and then have to have emergency surgery, etc. So there's a financial cost to the system as well as a human cost to not having a pharmacare plan for all people living in Canada. I think the savings that an implementation of a pharmacare plan would reap would be able to support some of the things that we've heard today by the other witnesses excuse me, put forward. The cost savings of a national public pharmacare plan would be able to support the programs and plans that so need that coverage, up to and including the long-term care situation that we have going on now. We could support them with additional funds for proper care and
Thanks.
levels of care delivery.
I'm just going to stop there because I'm going to squeeze one more question in. On March 30th, the CFNU said this: it took the Public Health Agency of Canada until January 2021 to acknowledge what unions and many experts have said all along. Healthcare workers are at risk of airborne transmission when in close proximity to an infected person. Yet PHAC still does not require healthcare workers in COVID-19 units and hot zones to wear protection from airborne transmission, such as N95 respirators. Can you tell us what the impact of that lack of guidance from PHAC is on frontline nursing staff?
Well, nurses know, and nurses know the truth, and we follow science and we make decisions based on scientific evidence. And we said right from the get-go that nurses and healthcare workers in the hotspots and dealing with COVID positive and COVID presumptive patients should have access to the PPE that's required, whether it's an N95 or something else. And I think the effects are going to be devastating. We've seen a number of healthcare workers already die from contracting COVID, and it just breaks our hearts because it's a tragedy that could have been avoided.
Thank you, Mr. Davies. So that brings our first round of questions to a close. I wonder if the committee is interested in a short snapper round, 30 seconds per party. Is any interest in that? I think there's some interest.
Sure, why don't we go 1 minute? I see we have 4 minutes. Why don't we go 1 minute per round?
Well, we can take a shot. 1 minute rounds generally take 8 minutes, but go ahead. Well, so we'll start with Mr. D'Entremont. 1 minute, please.
I think Larry was going to pick that up.
Okay, Mr. McGuire, then please go ahead. I'll start your time now. 1 minute. Mr. McGuire, do you have a headset or a microphone?
Yes.
There you go. There you go.
Thank you, Mr. Chair. Good to see all the witnesses, and thank you for your presentations. I just wanted to ask Dr. Collins, in previous discussions, we've looked at a number of the other issues that you've dealt with as well, and today you've talked about the critical care again, the recovery that's needed, that front door approach. One of those areas is in regards to long-term care and seniors as well, and I wonder if you could expand on some of the things that you've asked for there. You've looked for greater stay-at-home opportunities. I think one of your reports comes out showing $95 to keep a person in the home, $150 in a long-term care facility. Just some expansion on that, and then exactly how the vaccine rollout has occurred in our long-term care facilities and whether it's been successful at this point yet. I know that it's reduced the numbers tremendously in there, but just wanted to get your response in regards to the plan for long-term care in the future, probably as much as anything. Thank you.
Thank you for the question, and I will just respond with respect to vaccine rollout. We have seen a marked reduction in cases in long-term care in this third wave of the pandemic. which is a good thing. We have called and do support national standards that would improve oversight and accountability in long-term care going forward, and efforts to support seniors staying in their homes. We know that in a survey, 96% of Canadians that were 65 and older said they would do anything to stay in their home as opposed to go to a long-term care facility. So we do encourage collaborative discussion between provinces and the federal government to support senior Canadians in that endeavor. Thank you for the question.
Thank you, Ms. McGuire. We'll go now to Ms. O'Connell. Ms. O'Connell, please go ahead. 1 minute, please.
Thank you all. I'm sorry I can't ask you all a question, but I appreciate you all being here today. Mr. Weil, I wanted to actually pick up on what you were discussing, and vaccine distribution obviously is provincial and can vary. But I'm actually curious in your work and your advocacy in regards to things like showing a health card in order to get a vaccine. I could see that could be problematic if somebody is homeless or experiencing some trauma. And I know in my home province of Ontario, technically there shouldn't be these restrictions. However, there are different local health agencies handle it differently. Could you maybe elaborate on your experience and if there are any best practices we can share with provinces and territories?
Yes, thank you for the question. Yes, with the population we serve, it is a challenge because regardless of what ID they have, whether it's their birth certificate or whatever, many of our staff spend a lot of time as advocates, going to their home province, getting ID. I think the best thing we can do is there be a system, and I mean like a database, which we have in most of our cities, to accurately keep track of all these individuals that are getting their first dose. And of course, our concerns are for the second dose. Will they be available? So thank you for the question.
Thank you. Nous allons maintenant, Monsieur Thériault.
We now move to Mr. Thériault. Go ahead, please. Ms. Worsfold, in Quebec, the pandemic has led to some nurses exiting the profession, and that may be due because we still have a lot of work to do to recognize the professionalization of this job. It's an essential role. Do you agree with me that for that recognition of the professionalization, there have to be better working conditions, including what we did with personal care workers, an increase in their salary so we can find and retain that expertise, because if we lose that expertise, we'll lose a lot more than just what we would lose through injecting more money. Thank you.
Thank you for the question. I couldn't agree more. Working conditions are always our number one concern of the working nurse, the frontline nurses, and it's short staffing contributes to the working environment and the level of care that you can deliver. And working conditions are, yes, number one. Violence in the workplace is something else, and it's really had a spike during the pandemic, and that's a big contributing factor as well. Nurses don't want to go home at the end of their shift feeling like they haven't done their best and given the highest level of care to their patients, residents, and clients.
Thank you, Monsieur Thériault. We go now to Mr. Davies. 1 minute, please.
Thank you, Ms. Worsfold. I want to find out if you can give us, the committee, an accurate snapshot today of whether nurses, particularly those in COVID-19 units and hot zones, are they or are they not getting access to the proper personal protective equipment that they need, and why is the Public Health Agency of Canada not updating its guidelines with respect to airborne transmission?
I can't speak to why the Public Health Agency is not updating because the science is there, and something as recent as this week has come out again in support of the airless aerosolization of COVID. So I don't know why they're not. I can't speak to that. And it depends on where you are as to whether or not you have access to the proper protective equipment and access to it. So your safety really depends on where you live and if your employer is supplying you with the proper equipment for your own safety.
Thank you, Mr. Davies. So that really and truly uses up our time for this morning. I really want to thank all the witnesses for your time and sharing your time and your expertise with us today. I want to particularly acknowledge Ms. Worsfield. I know that you came off a long shift. You're about to go on another one. So I really hope you, after spending your morning with us, I hope you're able to get some sleep. But absolutely, I appreciate all of the witnesses today, and thank you to the members. And with that, we are now adjourned. Thank you all.
Thank you.
Thank you.
Merci.
Thank you very much.
Merci beaucoup.